Hey guys.
Hi, Ms. Knighton.
Morning.
Knighton.
So did y'all see that I changed things up a little bit on Canvas and updated it?
I watched all your videos this morning, but I didn't see anything past the first chapter 33 for the PowerPoints.
You didn't see 35?
I saw 35's PowerPoint, but not like a lecture.
Yeah. Okay, that's good. So I took 36 off. We're not going to do 36 anymore. And I'll talk about that more at the end. And I'll explain why you won't see a lecture recording for 35. We're going to get caught up. So for today, we are going to finish physical assessment, and I want to hit some highlights to make sure that you know what I'm talking about for some things. And if we have time, then I'll show you what I want you to do for chapter 35 and what the plan is. Was everybody able to access the PowerPoints for physical assessment and for chapter 35?
I was.
Okay, good.
Yes, ma'am.
Yes.
Good. Okay. So I think this is where I left off on the recording. And I feel like we're just beating it to death. But basically, when you're walking in the room to do an assessment on a child, it can be overwhelming trying to figure out, where do you begin? Do you do head to toe, toe to head? Do you listen first if the baby's quiet? Do you talk to the family first? Do you know what is the right thing to do? Well, there is no right thing to do in all situations. It depends. You have to use your clinical judgment. It depends on how sick the child is. How quickly do you need to act with your stethoscope and your other assessment tools? Do you have time to make nice with the family and gain some trust from the child before you jump into your assessment? Hopefully you do, but you're not guaranteed that. You have to use your critical thinking skills and your clinical judgment to decide how quickly you need to act. So, as far as, if everything is okay and a child is not in acute distress, and you decide that you are not in an emergency situation, then yeah, you need to consider stranger anxiety, and especially with the toddler age range, and you need to develop that rapport before you start your assessment. So how do you do that? You're walking in the room, you wash your hands, you're introducing yourself to the parents and to the patient. How do you start to develop rapport with the toddler?
You have to get on their level.
So you're going to literally get on eye level with the child and find something that is developmentally appropriate to do with them, whether it's sharing your equipment and letting them touch and feel, or watching cartoons with them for a minute and talking about whatever's on the TV, whatever it might be. Sometimes it's just having you be nearby so they can look at you and watch you talk to their trusted caregiver. And that alone will help go a long way in developing a rapport. So the book is just going to suggest a place to start, but it's not a hard and fast rule, and you have to be able to conform to the situation. If it's a new admission, what do you need to get ASAP? You tell me. New admission, what do we need?
Vital signs?
Vitals.
What else?
History.
What else?
Allergies?
Yep.
What brought them in for the day?
So we need all of that, of course, but before there's
Subjective
certain
information.
things. Yes, and there are certain things. You mentioned one, the vital signs. There's something else that we need as quickly as possible so that we can get it in the system in case we need to give a medication.
Is it like lab work?
What would that?
Blood draw?
No,
Allergies.
no.
The initial assessment by chance?
What are all medication dosages based on?
Wait.
Height and weight.
Weight. Their weight in kilograms. So we need to get that weight as soon as we can, you know, assuming that there's nothing else urgent that needs to be done right that minute. We need to get the weight. We need to get the vital signs. We need to get our stethoscope on them and listen to breath sounds and make sure they're moving air. You can do an assessment very quickly, or you can take your time with it. But the three things that stand out in my mind of essentials: putting a stethoscope on their chest and making sure they're moving air. So I know, okay, they're breathing, I've got a minute. And of course, with that is my visual assess their work of breathing. Very quickly, I can tell they're in respiratory distress or they're not. Number two, I need to get some basic vital signs so that I can trend. I need to see, you know, what's their pulse ox right now on room air. If they continue to deteriorate and I have to put them on oxygen, what if I've never even checked a SAT, you know, yet? So get that pulse ox, get your vital signs, get your stethoscope on them, and get a weight on them so you can get that in the system in case you need medications. How quickly you do that and what all you include in the middle depends on how sick they are. What vital signs do we get on kids? You think it's any different than adults?
No.
Nope. So there's 5 things.
Respirations, O2, blood pressure, heart rate and pulse,
And temperature.
and temp.
Yep. So, yep, that's it. Okay. And we'll look at each of those in more detail in a minute. So as far as how sick are they, you make a first impression when you first walk in the room. If they're smiling and playful or looking at you and preparing to run away, yeah, maybe they don't feel good. Obviously, that's why they're here. Maybe they're a little dehydrated. Maybe they have a rash. Who knows what it is that got them admitted, but are they in acute distress? Is their perfusion compromised? Is their respiratory status compromised? Is their pain unmanageable? Is, you know, how sick are they? So we have to ask ourselves, are they sick or not sick? Well, we know they're sick, but let's pretend there's a difference in sick and really sick. So are they sick or really sick? Do I have time? That's how you know if you have time to ask all those historical questions and develop that rapport and all of that sort of thing. Your first impression is very important. It tells you a lot. And the main thing being, how fast do I need to move? As far as developmentally age appropriate, you can tell right away when you walk in the room. Is the 10-year-old acting like a 10-year-old, or is the 10-year-old shriveled with, you know, muscular atrophy and curled up, sucking on their thumb in a crib because they have severe developmental delay with cerebral palsy. And even though they're 10, they're really more like a 1-year-old. So that is, that's pretty easy to take note of as well. So when you try to figure out what they're here for, what is their chief complaint? Do you really use these words? Can you tell me the onset, the duration, what kind of characteristics? Can you tell me, you know, how are we going to word that?
Can you show me where it hurts?
Or, you know, just even more basic than that, what brought you guys in today? Why did you get admitted? Tell me what happened. What's going on? Just an open-ended question. And if they give you a vague answer like, well, he was having some stomach pain for the last couple of days and I just can't figure out, you know, what's going on. So here we are. So there's a vague answer to your open-ended question. At that point, you need to clarify and you can get more specific with your questions. So when you say a couple of days, and you know, what does that mean? Sunday, you know, since Sunday or since Monday? Or when you say stomach pain, what do you mean by that? Where does it hurt? Can you show me where it hurts? Did you ever have to throw up? Did you ever have diarrhea? You know, and do you see what I'm saying about getting more specific? But you always start with an open-ended question, just getting them to tell their story. Has this ever happened before? If I have been asthmatic, it's one of the first things that I ask. Have you ever been in the hospital before? Does anyone else in the family have asthma? Same thing, like if they have pneumonia or something like that. Has this ever happened? Has anyone else in the family been sick with a respiratory illness? What treatments are you guys doing at home? Do you have a breathing machine? Does anything make it better or worse? And as far as what the concern means to the child and the family, that could be things like just being aware of the emotions in the room, the stress in the room, and asking, how are y'all handling staying up here with your son or daughter in the hospital when you have all these other children at home? What are you doing about working? Is dad still having to work? Who's taking care of the other kids? What about how do you feel about missing school, you know, right here at the beginning of the school year? Is that stressful for you, or are you happy to be missing school? That's what that's talking about. As far as the past health history, this is our questions about, were they premature? Why do I care? Well, lung issues are a potential. Neurologic delay, developmental delay is a possibility. Cardiac issues, GI issues, all of those things can stem from prematurity. If they weren't premature and they were full term, were there any complications at birth that could have led to any of these things that I just mentioned that could impact the current illness? If you have a kid that is asthmatic, why do you think I would ask them, is this the first time they've ever been in the hospital? Or have they ever been in the hospital with asthma? Why would I ask them that?
Know the frequency of attacks.
I can't hear you.
Okay, I said to probably document frequency of attacks.
Right, the frequency of attacks for sure. What would it tell me specifically about, so you can have attacks that don't necessarily put you in the hospital. If this information is telling me that this child has more frequent attacks requiring hospitalization, then I can infer that this child's asthma is either poorly managed or just extreme, very, very severe. They have a lot of triggers, or something puts makes them very susceptible to illness, that, you know, maybe that's what triggers them. But if I have a kid that their asthma gets triggered so easily and so frequently that it puts them in the hospital, then it makes me more concerned versus the child that has an inhaler and has to use it once or twice a month and has never been in the hospital. Who's more likely to get sicker the fastest? So obviously the first one. If they tell me they've been in the hospital before, then I say, have you ever been in the ICU? If they say yes, then I say, have you ever been on a breathing machine? Or ask the parents, you know, have they ever been on a ventilator? Because all of those things, even though it happened in the past, directly, you know, applies to this present illness, because I know, hey, this kid can go bad fast. They've been on event before because of their asthma. So I really need to be on my toes because they have potential to get bad quick. Any surgeries they've had before? What if they don't have a spleen? Why would a kid not have a spleen? Anybody know?
Birth defect?
No.
It was enlarged, or like, I guess, had an infection, they had to take it out.
Why would that happen? What kids would have an enlarged spleen and have to have it taken out?
Would it maybe be like a cancer patient?
Anybody
Like-
else have an idea? What about sickle cell?
Hmm.
Did you know that?
No.
Yeah, sickle cell, all those sickled misshapen cells get clogged up in the spleen and can cause infarcts, and that congestion from those sickled shaped cells can cause swelling in the spleen and pooling of blood, and it can make the spleen more likely to rupture, and they could die pretty fast from that. So that's a huge thing, especially if you know your kid has sickle cell, to find out if they still have their spleen. There are other issues where maybe the child had a bicycle wreck and ruptured their spleen and was bleeding, and they had to remove the spleen. What's the significance of not having a spleen? What does that affect?
The immune system.
The immune system, right. So, I mean, compared to had they ever had their appendix out, it's not as significant as a piece of data as having had their spleen out. The only thing having had their appendix out can tell us is that their current problem is not appendicitis. Diet and allergies. Let's see. And then current medications are big things to find out about. So answer this question for me. You've got an 8-month-old that is sitting on the mom's lap, chewing on a toy, and you need to start your assessment. What are you going to do first?
Heart and lungs.
Heart and lungs?
Mhm.
We agree?
Yes.
Good. So you're going to do your assessment according to their developmental age. As far as your approach, do you let them play with your stethoscope first? Do you jump right in and get straight to business? I mean, think about a teenager versus a 2-year-old. Don't try to play a game, an icebreaker game with your teenager that doesn't feel good. Just get what you've got to get done, or they're not going to appreciate being treated like a baby. Proper place for the exam. Is it okay to do an exam with the kid sitting in mom's lap or dad's lap? Do you have to lay them on the table?
No, you can take it in their
No,
lap.
take it in the lap.
Yeah, you'll probably get a better assessment if you keep the child calm. Now, if there's a wound or a diaper rash or something like that that you need to specifically see, because you know you want to undo that diaper and assess anyway, I would still try to do it with the parent's assistance. Usually they can reposition the child in their lap to let you see what you're trying to see. If not, save that till the end to lay them down. Save the crying till the end. Always assess the painful areas last as well. So, newborns and infants, you can let the parents hold the baby. You're going to listen to the heart and lungs in their belly while the baby is quiet. What's the trick for counting the heart rate?
6 seconds times 10.
So, because our as young people, the heart rate, they don't have AFib typically, and their heart rate is pretty regular. We can do a 6-second trick where we watch the clock and we count for 6 seconds. And if we get 14, we add a 0 on it, or multiply times 10. It's the same thing. You can multiply times 10 in your head. You don't need a calculator. So that 14 would change to 140. So we could quickly get a heart rate. And while our stethoscope's on their chest, we're going to get our respiratory rate. We need to count at least for 30 seconds, if not a full minute, to make sure our respiratory rate is accurate. And we need to raise that shirt up or unbutton the outfit and look at the work of breathing. We're going to talk more about retractions and assessing the work of breathing here in a minute. And then we'll finish the other pieces of our assessment. Palpate the belly, feel the pulses, things like that. So what do you do if they're making all this noise? Not really crying, but they're just noisy. How do you count respirations? How do you count the heart rate with all that noise? Honestly, you just get used to it and you have to tune it out. The hardest thing is the respiratory rate. That's why I say it's safer to count for a full minute when they're doing that talking, whining, short respirations, just lots of little pauses. It's very hard to be confident that you got an accurate respiratory rate if you don't count for a full minute. Oops, sorry, we don't need to hear that again. So what if they're crying? Like all out crying. So for example,
Maybe hold off on the respirations until they're calmer.
great idea. So hold off on the respirations till they're calmer, because you don't want the fast respiratory rate to reflect their disease process. They're fast because they're crying and they're upset, not because they're sick. So when you're checking vitals on admission and every 4 hours, that's to trend if they're getting better or worse. So you don't want to be misleading in your assessment, but you can still listen to breath sounds, because between each of those cries, they have to take a good deep breath. And that's a perfect time to listen to breath sounds. Okay, toddlers. Now, you may get confused because you might see a question that says something like, when is it appropriate to make a game out of your assessment? And toddlers is incorrect. But here I'm saying incorporate play into the exam. So let me distinguish what that means. A game requires cooperation and following directions. That is more appropriate for a preschooler. And they also have that sense of initiative. So they want to play a game and win the game, you know. A toddler wants to play with your stuff. They want to play by themselves. They want to play, they want you to be there, and they want to make all the rules themselves. They don't really care about rules. They just want to play with the stuff. So these are the ones that you let them touch and hold. And but do you understand the difference in a game and play? And I know that seems like a trick question, but I've seen it mess people up before. So again, we're going to let the toddler stay in the caregiver's lap. Let's see what kind of noise this kid wants to make. Oh my. Yeah, we don't need that. Now the preschooler, this is the most fun age with that magical thinking and that imagination. You tell them you're going to take their blood pressure, and all they hear is you're going to take their blood. You tell them they're going to get ready to go down for their CAT scan, and they don't understand why you are trying to hurt their cat that they have at home. So you have to think about the wording of things, and y'all know about this from the previous chapters. But that sense of initiative that they have will allow them, or allow you to gain their cooperation if you are smooth with your wording and you take the time to gain some trust and get them to play the game and be a participant in their care. But you just have to watch your wording, because they do imagine the worst and they fear invasion and mutilation. So there's another scream. Oh my gosh, what was I thinking? Now this is the hardest age for me, is the school agers. It's, for example, before I try to explain this, when I tried to explain it to my last class, I wished I had played this recording first, and then I wouldn't have sounded like such a butthead. What are you doing? Could you understand what he said?
What are you doing?
Yeah. And he sounds angry and scared, and like he's probably trying to, we're all holding him down and he's kicking, and it seems, you know, he'd probably even try to bite me if I came close to him. He's terrified. It's very difficult for me to, it's difficult with this age. With a child, with a baby or a toddler or a preschooler, I get it. I understand that they don't understand. But when I have a school age child that I know is very concrete and realistic, and they should be able to understand, but their fear won't allow them to accept the situation, it's very hard. It's hard to console them. You can't just give them a sticker afterwards and their pacifier and console them and think it's going to be okay. They get angry, they hold grudges, it's hard. This is a very hard age. And when you get family members involved in the mix and you get mommy syndrome, you know, if they would just leave me and the kid in a room by ourselves, he'd probably be fine. But when you get that family dynamic mixed in, they tend to show out a little bit more for the parents. And that's not because they're trying to be bad. It's because they're letting their true fears and frustrations show, because their mom's there or their dad's there. And so there's more whining, there's more begging, there's more defiance when the family's there. If it's just me and you, there's nobody to whine to. It's just that you don't even know me. You know, you're just at my mercy, and we get a little bit more cooperation that way. And it's not nearly as traumatic, it seems like, but it's just complicated. This is a hard age. It can be. Don't lie to them. They're waiting to catch you in a lie. What are you doing? Okay. And then the teenager, they expect to have privacy. They expect for you to have an attitude of respect towards them as if they were another adult. They feel like an adult. They want to be treated like an adult. Our job is to remember that on the inside, they are not an adult yet, not completely. They're in between. They're not 100% adult, even though they want to be. And we have to know that those childlike feelings are still there and all of their coping mechanisms are not fully developed. At the same time, portraying that attitude of respect from one adult to another. Well, I think we get to that on another slide. So they're pretty easy. It's just, they may be easy, but that doesn't always mean that you're doing your best work just because it's easy. Teenagers, as a general rule, tend to just lay there and be quiet and don't argue much and just let you do whatever, and they bide their time till they can get out of there. That doesn't mean that because they don't put up a fuss and they're easy, that doesn't mean that you don't need to delve a little deeper sometimes.
You know, there are times that I just really hate him. Like, I don't even matter anymore.
So this goes on and on and on, but it's basically giving you an example of the drama that you either get the quiet teenager or the dramatic teenager that wants to tell you their whole life story. So in this one, the nurse is preparing to assess the lung sounds of a 3-month-old that is being held on her belly by her mom against the mom's upper chest. So mom's holding the baby belly to chest. Which technique should the nurse use to obtain an accurate assessment? So turn the infant on her back prior to beginning the assessment. Warm the stethoscope before placing it on the infant's shirt. Assess the lung sounds from the apex to the base bilaterally. Identify the hyperresonance heard as normal because of the thin chest wall. Place the baby flat while listening to the lung sounds. Auscultate the lung sounds through her back. I'm pretty sure we have 3 correct answers.
Maybe BCF.
So C is 1, and F is 1, and D is 1. So the reason that the writer of this question does not like B is because it says on the infant shirt. So I guess according to the textbook, you should be stethoscope to skin. But I'm going to tell you in clinical, do not wake up a sleeping baby by putting a stethoscope on their skin, under their shirt, or however you have to get to their skin, because no matter how much you warm up that stethoscope, they're still going to feel it and it's going to arouse them. And I say this too because you can hear just as well with your stethoscope on a thin shirt, like whether it's the gown, the hospital gown, or a onesie. You can hear, I promise, you can hear just as good. There's no need to go through their clothes. Now, if they have a thick wool or a fleece Old Navy jumper on, then yeah, you're probably not going to be able to hear as good. But most of the time in the hospital, or they're either already naked or they just have a little onesie on. And it will be in your best interest to attempt to listen through the shirt before you ruin your chance and upset the baby and have them crying, insisting that you get skin to skin. So I'm not going to trick you with this on a test. But for those of you who have been in clinical and listened, then you know what I mean. You can hear just fine through the shirt. If you do go skin to skin, make sure you warm the stethoscope first. A 4-month-old is sleeping during her first well infant checkup. Which assessment should the nurse do first? Inspection, palpation, percussion, auscultation.
Inspection.
So is it inspection or is it another one? We had people going back and forth in the last class on this
Well,
one.
you could oscillate because you don't, you don't want to do palpation and percussion while they're sleeping. You want to get what you can while they're still asleep.
Right. So with inspection, because my mind goes straight to inspection as well, I think about the general impression and I'm inspecting their skin perfusion, just what I can see. But then someone else pointed out, yeah, but with inspection, really you're talking about everything down to the diaper area. So in that aspect, the correct answer being auscultation makes more sense. I know I'm going to listen because fairly early on because the baby's asleep. So when I go back to the stem of the question, the key word here is sleeping. That's how I should know right off the bat that the answer is auscultation because they gave me a hint in the question that the baby's asleep. But I understand why you might want to go with inspection. On page 720, there is a section called a critical thinking exercise. Page 720, please write that down and read that. The nurse is performing a physical assessment of a 16-year-old girl. Which of the following is a recommended guideline for interviewing a child at this developmental stage? During the interview, ask the caregiver to answer, any questions that the teenager is too embarrassed to answer. Keep up a running dialogue with the caregiver, explaining each step as it is performed. Perform the genital exam first and then use a head-to-toe approach to other systems. Explain to the caregiver that the teen needs privacy and ask him or her to wait outside the room.
D.
Good. So I've never worded it this way before because that would just be awkward for everybody. What I have done is said, I act real like, oh, I do this every day. I'm just got to do my assessment real quick. This is no big deal. If I think it's no big deal, maybe you'll think it's no big deal because the teenager is probably embarrassed. So I would just say something like, so, hey, I'm fixing to have to do your assessment and I've got to check your wound, down there. So you okay with me asking mom and dad to step out for just a second and we'll get this knocked out. And so that kind of lets everybody in the room know that you guys need to leave and I'm asking her permission first, but I'm saying it so she won't have to say it. And I'm trying not to make anyone uncomfortable. I'm trying to make it obvious to the parents that I'm about to have to expose part of her body and she might be embarrassed. Whether she is or isn't, I've allowed for an opportunity for them to leave. If she really wants them to stay, then she can say, no, they can stay. That's different. But I'm going to assume she wants them gone and I'm going to take care of it for her in a nonchalant kind of way. Any questions about that? Okay. So for those of you that haven't been in clinical yet, I wanted you to see this, and this is why this PowerPoint is posted on the clinical Canvas page as well, just so you can see this stuff. We have monitors like this in every room. So you won't need to bring the vital sign cart to the rooms because you have everything you need in the room except a thermometer. Occasionally you need a new pulse ox probe. Sometimes the patients are on the full cardiac respiratory monitor with the electrodes. Sometimes they are just on a continuous pulse ox. Sometimes they're not on it at all. And the monitor is off between checks. And I'll teach you how to work it once we get in the hospital, but you can use this equipment every time you check your vital signs and you just have to share thermometers. As far as the thermometers go, we have the oral axillary thermometer that looks just like the one in the bottom left corner of your screen. Axillary is always right. You can use that on any age patient. And if they can cooperate and haven't been drinking anything cool, then you could use oral. We have the disposable digital thermometers for patients on contact precautions, or if they have a rectal temperature ordered. We don't ever get rectal temperatures on babies unless we have an order. It's considered an invasive procedure. So that's different than how it used to be. And then we used to have a tympanic thermometer and it broke, and we do not have a temporal thermometer anymore. Some of the doctors were not happy with the readings that it was giving, and it kept breaking. So whichever method you use, be sure you document if it was axillary or oral. For the blood pressure cuffs, we've got the orange, green, light blue, and dark blue. So we've got an infant cuff, a toddler cuff or small child, a small adult, and a large adult. And wherever you get your blood pressure, make sure you document the extremity. The right upper extremity or right upper arm is the most accurate. But as you can see in this picture, when they're very small or even the toddler age, it is much simpler to wrap it around their lower extremity. It seems less invasive in a way, because if you wrap it around the upper arm, you can see how you would have to pull their arm away from their body, and the edges of the cuff kind of scratch against their chest wall, and it's irritating to them. And you're going to have to wait for them to calm down before you can press go on the machine. So it's just a little easier to do it on the leg. But the problem is sometimes we get falsely elevated blood pressures or pulse pressures that are too narrow. They're not accurate because of the location. So if you try it on the leg and your numbers don't sound right, then you need to redo it in a different location, preferably the right upper extremity, or the nurses are going to say something to you. The pulse ox, we have lots of options besides just the fingers. We can do the big toe if it's a big kid or a toddler with the toe big enough. But on the little ones, I like to wrap it around the foot or the wrist or even the palm. It works pretty good. Once you get it in position, wrapped around your location, you're looking for that good, strong waveform and a heart rate that matches up with your assessment. Once you get a number, hold position, because the number will probably go higher, and you want to document the highest reading possible. If they do have an order to be on the cardiac monitor, or if we're worried about their status and we choose to put them on a monitor until we can get an order, we have these packages that look just like what you see in the picture, neonatal electrodes. So they're the same electrodes that we use on babies. They'll work on the big kids just as well. White on right, smoke over fire. It tells you on the cable where to plug them in, but the white on right, smoke over fire never changes. If you can just remember which side is the right side, white on right, then you can figure out where the black and the red go, smoke over fire. Don't forget to document your pain scores. 3 different methods: numeric, which is your 1 through 10, if they're old enough to understand that scale. Wong-Baker FACES scale, you can just say FACES. You have to be able to show them an example. You have to show the child the faces, and they point to the face that represents how they feel. It is not you making that determination for them based on what you see in their face, because children cope through play and different types of distraction techniques So they may look fine to you, but when you ask them, they say their pain is a 6 based on the FACES scale, and that's what you document. It is a self-reporting scale. And then if they're nonverbal and they cannot report their pain score, either because developmentally they can't do it or because they're asleep, you can use the FLAC scale. And you have an example of this on Canvas that you can print out and have with you in clinical, and the nurses have it on their badge so for a quick reference. So you assess your child, and then you come out of the room and you can assign them a score for face, legs, activity, cry, and consolability. No matter which scale you use, make sure you're doing this consistently every 4 hours or more often as needed, and that you document the scale that you used, FACES, numeric, or FLAC. We've already done the growth chart practice. I know I gave you 3 different sheets, but typically they come on one with the length and weight on one side and the head circumference on the back side. So it's all about the trend. If the child you measured was on the 5th percentile, as long as they stay around the 5th percentile, they're just petite. That means that 95 out of 100 kids are bigger than them, taller, or way more than them, but they're still within normal range. They're just on the lower end. If they're in the 95th percentile, they're big. They're just a big kid. They're within range, but they're bigger than 95 out of 100 kids their age. So we worry when we trend, we plot the child over time, and they've been the 25th, 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 and now all of a sudden they're the 75th. That's not normal. Or now all of a sudden they're the 10th percentile when they've been the 25th their whole life. So that's how this can be so valuable. These are examples of the scales that we have at the hospital when we get their weight on admission, or if it's a daily weight. We're going to zero the scale. I put a baby blanket on the scale, and I get a clean, dry diaper of whatever size the child is in. Zero the scale, okay? With the baby blanket and the clean, dry diaper. Then I'm gonna take away the clean, dry diaper. So now I just have the scale with the baby blanket, and it's giving me a negative number because I took away the diaper. Then I have my baby. I'm going to get them naked in a clean, dry diaper because I don't like taking chances with babies that are not diapered. But I need their diaper to be the same size and to be dry. I've already accounted for the weight of that diaper when I zeroed the scale. So now I set my baby on the scale. I have a helper with me, always take another student in case they decide to make a jump for it. And I get their weights because we speak pounds and we speak kilos. The picture on the bottom in the black square, that is a diaper scale. So if you have a baby on strict INO, that means we need to weigh their diapers. If they don't have a catheter, then the only way to get an accurate output is to weigh their diapers. How does that work? Somebody tell me. How can the weight of a diaper reflect the amount of urine? Does anybody know?
Because fluid has weight.
Yeah.
Right, but isn't it like 1 ounce is 1 milliliter or something like that?
Something like that. 1 gram equals 1 milliliter. 1 gram equals 1 milliliter. So your scale will be set, the unit measurement will be set in grams. And your diaper, you will again say if they're in size 2 diapers, you'll zero the scale with a size 2 diaper and then put the wet diaper on the scale. And if it weighs 42 grams, that equals 42 milliliters. and that's what you record for the output. If they're routine INO, then we're just just documenting the number of wet diapers and the number of dirty diapers. As far as the other measurements, of course, we'll get their length. If they're, if they can't stand up, we'll stretch them out on the bed and get their length with the disposable tape measure. If they're old enough to stand up, then we'll get their weight and height on the standing scale. And the only other measurement we're required to get is the head circumference for those that are 2 and under. As far as the abdominal circumference and chest circumference, that is if it's ordered or your nursing judgment tells you we need to follow these abdominal circumferences because they're here with the distended abdomen. You know, you may not have a specific order to trend the abdominal circumference, but it just makes good sense to do so. So that's the great thing about being a nurse, is that they expect you to use your noggin and decide when it makes sense to do something. And you don't have to have a doctor hold your hand and tell you, would you please get an abdominal circumference? Because you kind of already did that. I'm not telling you to do things without an order, but I'm saying we have enough sense to know this isn't going to hurt anything, and I am capable of measuring their belly circumference without an order. Okay, your skin assessment. Pink, warm, dry. Why would a child or a human, why would a human not be pink, warm, dry? What else can they be?
They can be blue, cyanotic for lack of oxygen.
Yes, and in the picture at the top of the screen, you have circummoral cyanosis around their mouth area. And then the bottom picture, you have a representation of pallor or pale lips. But you should be pink, warm, and dry. That's our normal. That's our expectation. If you're not pink, then you're pale, cyanotic, dusky, flushed. If you're not warm, then that means you're cool or you're hot. Why would you be cool or hot? If you tell me in a legal documentation that your patient is pale, cool, and clammy, instead of pink, warm, and dry, something's wrong. And I need to be seeing further explanation, further documentation. What did you do about it? Who did you let know? You know, there's got to be follow-up there because something's wrong. They should be pink, warm, and dry. A clammy means, you know, that's diaphoretic. If you're not dry, you're moist. And if you tell me that they're moist, I'm going to say, why are they diaphoretic? Oh, no. I didn't mean they were diaphoretic. Well, I just meant that they weren't dry. They're just kind of, ugh. Well, greasy teenagers don't count for moist. That's not what it means. Pink, warm, dry. Dry means not diaphoretic. If you tell me they're moist, I'm going to be like, you know, why are they diaphoretic? Are they nauseated? Are they in pain? Or if you tell me their skin is hot, I'm going to say, assume that they have fever. So I'm going to be looking in your documentation for evidence that you treated their fever or that their fever is being treated. Someone asked me in the last class, how do you document pink skin on an African-American patient? Please, someone tell me. What do you say about skin? No one wants to speak.
Normal for ethnicity, but maybe.
Yeah, that's what Dr. Care wants you to say. But what in the blankety blank does that tell me about cardiac output and perfusion? That's the whole reason. And it irritates me that DocuCare and every nursing assessment form I've ever seen, not just DocuCare, has an option for appropriate for ethnicity, because that is misleading to the purpose of our assessment. The purpose of the skin assessment is to assess perfusion. pink, warm, dry. It's all about perfusion. And no matter if you're from Thailand or Zimbabwe or England, we all have a heart that beeps and pumps blood. And we should all have pink mucous membranes and pink nail beds, pink palms, pink soles of our feet, pink tongues, pink gums, pink conjunctiva. There are parts of us that should always be pink, always. So it can be a little more challenging if you're not used to assessing pinkness on a dark-skinned patient, but you just have to know where to look. Because if they turn cyanotic, those places I just mentioned are going to be cyanotic. They're going to be dusky. They're going to be gray, just like the palest person you've ever met. I don't care how good of a tan they have. So if you want to check appropriate for ethnicity because it's there, go ahead. But be sure you tell me some more stuff, because let's say you stop there and you told me, yep, Amy's color is appropriate for her ethnicity. Okay, my first response is, you need to get out of my business because you don't even know my ethnicity. I mean, really, why do you have to know that? What does that have to do with your physical assessment of me, my ethnicity? I just don't get it. And it bothers me too, because it's taking away from the purpose of the assessment, the important stuff with cardiac output. And I love to preach that every semester. So thank you for the opportunity, and please ask me any questions that you have about that. There are other instructors that have never even considered what I'm saying, and it doesn't bother them, but it's not because I'm not right. It's just because it doesn't bother them. They've never really thought about it or had it pointed out. I don't know. But they won't blink an eye, maybe, but it drives me insane. If you have an argument for me, then let's talk about it. Does it make sense what I'm saying? Y'all are too quiet.
It makes sense.
Makes sense to
It
me.
makes sense.
Are there any dark-skinned students in this class? Are there any African-American students in this class?
Yes. Well,
Do you agree? Do you agree that you have pinkness?
Of course, because
The parts
yes, because obviously, like when you do a cap refill, you're not going to be seeing black if I'm healthy. Like, do you understand? Like you rightly said, there are parts of your skin, like your conjunctiva, that would always show signs of pink, pinkish in them. So
right.
yeah, I agree with you.
Right. Yeah, and they probably the people with darker skin never even question the fact. It's white people that think, well, how do you check that a darker skinned person is pink or not? They're pink. When you see somebody whose nail beds, lips, palms aren't pink anymore, then you'll recognize real quick, where did their pinkness go? So just be aware of that. Does anyone not know what a Mongolian spot is?
I don't know what that is.
I
My-
don't know what that is either.
Okay. And I remember the first time I ever saw one, and after that, it seemed like I saw them all the time. I know African-American babies and there probably are other races as well of maybe of Indian descent. I don't know, the darker colors tend to have, not tend to, but they can have a birthmark on their backside. It can be across their sacrum, across their one buttock, anywhere along their backside that looks like a bluish green bruise. It looks like a fresh bruise, like they got whacked with a belt. And it can scare you the first time you see it. So be prepared anytime you do an assessment of a dark-skinned baby to find a Mongolian spot. When you see something that looks like a bruise, then you ask the caregiver, is this a birthmark or is this something new? And they'll say, oh yeah, that's a Mongolian spot. You know, he's had that since he was born, because the parents are used to being confronted with, you know, child abuse issues.
Yeah.
They're-
My twins had them, and the first time daycare saw them, they like called me like I was like beating them.
Yes. So I promise you, the parents will know that it is a Mongolian spot, and they will quickly educate you. So just, you know, just I try to just act like it's no big deal and say, oh, they have a Mongolian spot, or is this something new that's popped up? And they'll appreciate that you recognize that it's not a bruise. But you do have to ask just to make sure, of course. If that, I just say, is this the birthmark or is this something new? And they'll tell me. And then any significant scarring that you see, because, you know, usually on the younger kids, a significant scar, especially on their torso, is indicative of a surgical procedure that we would need to know about. On this page, I just wanted to point out about modeling. I'm sure some of you have the type of skin that when you get cold, or maybe just for no reason at all, you get blotchy, especially on the thighs and maybe the outsides of your arms. Y'all know what I'm talking about?
Yes, ma'am.
Okay, so some of us do it all the time, but when you see, it looks, modeling is exactly that, where it looks like red and white, red and white, red and white patches. So when I see that on a patient, my first response is to the patient or the caregiver, do they model like this a lot? Is this normal for them when, you know, when they get cold or whatever, does their skin do this blotchiness, or is this unusual? And see what they say. I don't model routinely, but I remember many of my friends did growing up when we would wear shorts, and I remember seeing girls that would model, but I only model when I'm very sick. And that's one of the ways I can tell when I'm super sick. So it's not necessarily a sign of poor perfusion, but it can be a sign of poor perfusion. So you just have to know what's normal for them. True or false? The nurse is examining an infant and documents cyanosis. This condition is a decreased pinkness in light-skinned children or an ashy gray color in dark-skinned children caused by anemia, shock, fever, or syncope.
False.
So what would be the correct term?
Well, the cyanosis would be that they would be blue, not pink. So
Right. So we're talking about pallor in this case. So in darker skinned people, the pallor may appear. So when you're looking at the palms and the soles or the lips, they have more of a gray, ashy gray tint to them. The pinkness is just gone. When you're assessing fontanelles, remember, we do not assess the posterior fontanelle. It closes pretty early, I think by 6 weeks. But the anterior fontanelle, on average, closes around 18 months. It can close anywhere from 12 to 18 months. So we just say across the board, if those 2-year-olds that we're going to do the head circumference on, if they're 2 and under, assess for a fontanelle to see if it's still open. Knowing that they should close by 18 months. As far as documentation, I say soft and flat would be the expected normal documentation for fontanelles. I've seen in a textbook where it says firm and flat, and I shy away from the word firm because your abnormal fontanelle would either be sunken or depressed, or tense and bulging. Tense sounds like firm to me. When I picture a tense, full fontanelle that's you know, getting ready to bulge or something, firm just, it scares me. It sounds like a scary word. Soft and flat doesn't scare me. I don't know. It's just, but tense and bulging, it should never be. Sunken, it should never be. If you feel like the fontanelle is sunken, because I've had episodes where personally I would call it sunken. I would ask mom, hey, does their fontanelle always sink in a little bit like this, or is this not normal? The parents know, and they say, oh, it's always like that. Or no, actually, I've never seen it that sunken in. And either way, I might document that it's sunken, but I would follow that with mother states this is normal for patient. If she says,
Is that picture a normal, or is that one sunken in?
so I think that the picture, I don't have the words here, but I think this is a normal example, but it looks like it's sunken in, doesn't it? And that's what I'm saying. A lot of times when you feel them, your first impression is that they're sunken. And it's not until you do a lot of normal assessments that you can identify one that's truly sunken. And on that note, on page 726, it talks about the different head shape terminology, because depending on how their bones of their skull are put together and shaped, it can make them seem sunken when they're not physiologically sunken from dehydration or something. So read the section about head shape terminology on 726, please. As far as their eye assessment for children, whenever you're documenting on DocuCare about equal, round, reactive to light, that's your pearl. If you're going to say they're reactive, which you have to do, please follow that with brisk or sluggish. Like, you just have to do that. If you saw them react and you, to the point that you were able to document they were reactive, then you should be able to say that they're brisk. If you had to search and finally you saw them react, that's a problem, and I need to know about it. We shouldn't have patients with sluggish pupils on the floor. So please don't forget to document brisk or sluggish. If you were unable to assess accommodation, leave off the A. Don't assess it if you didn't do it. I mean, don't document it if you didn't do it. And I guess by now you've realized that on DocuCare, it gives you an option to do both eyes or to document them separately if there was a difference in the two. But if you're gonna do, if they're the same, if they're equal, then you only need to do the first column. Okay. So take it off or raise it up. Be sure you look at the chest wall. There is no options. You must examine the chest wall for retractions and for work of breathing, which we will discuss shortly. Here, if you open the PowerPoint in PowerPoint mode, this is a link, or should be a link, for you to be able to assess heart and lung sounds or listen to them. Let's see. All right, retractions. So, hang on. So anybody know what we would call this kind of retraction?
It's like pigeon something.
So hang on a minute. I want to go backwards. I think I forgot to tell you something. Yes. On this page, I had a note to tell you, page 735, please read about pectus excavatum and pectus carinatum. So pectus excavatum is where the chest sinks in, and it's just kind of the way they're born. And carinatum is where it goes the opposite direction, like a pigeon. It's important to recognize, because with pectus excavatum, it looks just like this picture where we have a child that is having severe sternal retractions. The sternum, the breastbone here, is sinking in. This would be a sternal retraction. if I document that my child is breathing, their breathing is labored, I have to explain what that means. If I say they're labored with tachypnea or they're labored with retractions, I have to explain what that means. What kind of retractions and how bad are they? I document my retractions by type and by severity: mild, moderate, severe. So I would say for this baby, severe sternal retractions, because I just don't see how it could get any worse. That's how I know if I'm going to say it's severe or not. If I could put my finger into that hole and it feels like I could touch their spine, you know, they're sinking to the backbone, it can't get any worse. If it's not that bad, but it's obvious, then I'm going to call it moderate. If I'm having to search for it and be like, are they retract? Yeah, they are retracting a little bit. Yeah, they do have some sternal, but I'm having to look, then that's mild. But it's important that I start with a baseline assessment so that I can trend it. Either they get better or they get worse, and I have objective data to notify the caregiver about. Here we have intercostal retractions, where costal meaning the rib cage, the ribs, and I can see the negative inspiratory force of respirations is causing, that negative pressure is causing the musculature to sink in between the ribs. That's intercostal retractions. And this is trying to be called severe, but depending on, I'd have to see it in 3D animation to decide if it was moderate or severe. And it's just a judgment call. You're their nurse for 12 hours, so you decide what you want to call it upon your first assessment and trend it from there as the day goes on. What about this kid? So what I see different here, it looks like I have some mild sternal retractions here, and I hope you can see how there's obviously, I'm going to say moderate, there's obviously a divot here in the chest, but it could go deeper. It's not that deep. You see what I mean? Also, I can see the outline of my lower rib cage. So this is called subcostal retractions, when it looks like you could put your hands up under their entire rib cage and just pick them up by their rib cage. You can see the outline of it. So we've got some moderate sternal and subcostal retractions. And then finally here, we might have some mild sternal retractions here. Again, I'd have to see it live to be able to tell. We have for sure some intercostal retractions on the edges. I can see where the skin is sucking between the rib cage. And we definitely have subcostal retractions, where I can see the outline of my lower rib cage. Those are subcostal. It also looks like the baby's been swallowing a lot of air. We have a big belly, and if we were watching the baby breathe, most likely he's tachypnic, and we would see an exaggerated abdominal breathing. So kids less than 6 or 7, whatever your book tells you, their primary method of breathing is abdominal breathing. They depend on their diaphragm to breathe. So they use those belly muscles. If they really jump out at you, like all you see from the bed is that belly going up and down, up and down, up and down, even though you know abdominal breathing is normal, when it seems like crazy obvious to you, it is appropriate to document exaggerated abdominal breathing noted. That's just another way of explaining what you mean by increased work of breathing noted. That's too vague. Seriously, that's not objective at all. That's a very vague statement, because how will you trend a statement like that? Yes, they have increased work of breathing. What does that mean? You've got to give me details so I can trend, because they may still have increased work of breathing at 7 p.m. tonight when I leave, but they're better. I've got to be able to prove that even though they still have increased work of breathing, they're better than they were when I got here this morning. And the only way I can do that is with details. In this slide, it shows you, again, let's see, intercostal we talked about, sternal, substernal, if it's underneath the xiphoid process, subcostal we talked about. Now, if you have an upper airway obstruction, either from croup or a foreign object, you may see supraclavicular retractions or suprasternal. So be familiar with these words. You can't make up types of retractions. They've got to be legitimate. I think you're familiar with how to document your abdominal assessment. When you do DocuCare, I'm looking for 3 things in particular. For sure, have check marks for 3 things on the abdomen. You can check more if you want to, but firmness, are they soft or firm? Tenderness, are they tender, non-tender? And shape, are they round or flat? So shape, tenderness, and firmness for sure. Add anything else that you want. For the musculoskeletal system, be sure that you clarify if they're capable of active range of motion or if they need passive range of motion exercises. Either they can move by themselves or not. Let's see. For your neurologic assessment, page 745, box 3310 and table 33.3. Page 745, table 33.3 and box 3310. Review that about the wording for your neurological assessment, and please be familiar with the Glasgow Coma Scale and make sure you're documenting that. It is their level of coma, their maximal ability neurologically of performance. It's not, did they open your eyes when you walked in the room because they had been asleep and you woke them up? It's, can they open their eyes whenever they want to? Or do they open their eyes only to noxious stimuli, to pain or something like that because of their level of coma? So be sure you're comfortable documenting the GCS. Any reflexes for infants that could be indicative of a neurologic disability, and consolability for infants. An infant that is incapable of being consoled or is inconsolable, that is a neurologic red flag. So anytime you document that the infant is crying, be sure you follow that with easily consoled by caregiver, easily consoled by nurse, something like that. Kids can be upset, that's normal, as long as they can be consoled. But a baby with a high-pitched cat-like scream that cannot be consoled is a warning sign. And then finally, your other assessments to include your IV assessment. This is a picture here. If you haven't seen, that's a no-no, which is the Velcro elbow restraint that we use as an IV protector. We just wrap it around the IV in a lot of the patients just to secure the, kind of like an arm board, and to protect the site, keep the kid from messing with it. So if they have a no-no on, sometimes we don't have the IV wrapped up in as much tape, and you can just easily unvelcro the no-no and assess your IV. But if your IV is wrapped up with a lot of gauze and tape to protect it, then we just assess the fingertips or the toes distal to the IV site and the skin proximal to the IV site. And we would document, you know, skin, fingers pink and warm, or skin pink and warm, distal and proximal to insertion site. And every time I go in the room, I'm going to assess that dressing and make sure it's still dry. There's no evidence that we have any kind of infiltration as far as looking at the dressing goes. And if the IV was infiltrated, eventually, if they could not tell me it was hurting, eventually those fingers would get cold and puffy and stiff. And it's an awful feeling when you go in the room and it was a newborn or a little baby that could not tell you what was wrong or that it hurt. And their IV has been infiltrated for so long and their hand is so stiff. When you take the tape and the arm board off, their hand, they're just frozen in place the way their little fingers were wrapped around the arm board because their hand is so full of fluid. So be sure you go in that room and assess every time you go in there. And I teach the parents what I'm looking for. And I teach them to feel those fingers and toes and make sure they're just as soft and warm as they are now in 2 hours. And after that, and after that. Diet, if they're getting formula, be sure you document exactly the type of formula. Safety issues, the caregiver being present at bedside is a safety issue. Side rails, bed low and locked. Children love to press the buttons on the bed and you'll walk by and they'll be trying to touch the ceiling because they'll have the bed up as high as it can go. Bed low and locked, side rails, caregiver at bedside, whoever that is, call bell within reach either of the patient or of the caregiver. So every time, because of the extreme fall risk we have with kids, every time you close your note, end it with some type of safety assessment. Okay, so that is the end of this slide. So now let me show you something else. If I can remember how to do it. Maybe. Hang on, I'll figure it out. Maybe I'll figure it out. Exit. Okay. Now we want to look at the ill child. When y'all, this is not very much at all. This is only 24 slides. And when you go through here, if you will print out my notes, then you'll see, like here I say, why would a child be feeling stress in this situation?
What is
And
that?
I would want you to think about it. And then here, I talk to you about the things that they're feeling in my notes section. Then we have the anxiety. Then I take it by group, infant, toddler. You do need to know how hospitalization affects the infant as compared to the toddler. See here, high risk for stress. And all of this should match up with what's in your book. Then it talks about the treatment room a little bit, school-age children, and then the teenagers. A lot of this is just repetitive from stuff we've already talked about, and it ought to make sense to you. It just has, you know, just points out some things to you as far as their psychological response to being in the hospital, and then also talking about the parents, the playroom, and child life. Some tips for procedures and giving medications. This video about child life is the same video that I posted in Canvas. So you have two different places where you can view that. It's just like a 6-minute video about how child life should be and can be. And then, let's see, this is the short editorial that I posted, Empowered by Nurses. It really goes more along with the next chapter that I cut, but it's just too good. I didn't want to leave it out. It's not necessarily for a test. It's just really, really good. As you can see, Justice has problems, has developmental issues going on, and her mother, they've been in and out of the hospital so many times. Her mother wrote this editorial from Justice's perspective, talking to you as a nurse and how she wants you to see her and to treat her. And I just thought it was very eye-opening. And this is this is a piece of that, article. So that's it. There's no reason why I need to do a recording for this one. I don't feel like. I think it's all very self-explanatory along with your chapter. And I think that we can just get caught up. So this is what I'm going to work on posting in Canvas for you, an updated course calendar. We have finished physical assessment. Okay. I will post today's recording as soon as it uploads. You are going to read chapter 35, download the PowerPoint with the presenter notes and review those with your chapter, read Empowered by Nurses, watch the Child Life video, and then I added the IV placement and assessment videos just because I haven't showed you those yet. And remember that everywhere, every nurse does it a little bit different. So if you see something a little bit different than the way we learned it, it's fine. It's not a big deal. Unless you see something that's unsafe, don't worry about it. Just learn from everything that you see. And then of course, our class meeting was not from 9 to 10:30. I'll fix that for y'all's. And then next week, we are going to start on chapter 45. So be watching for that to get posted. I will have a recording to go with that. And the only assignment I have up so far is for your test question for exam 2. So on exam 2, we will have physical assessment, chapter 33, chapter 35, the ill child, and the first part of chapter 45. And then our test is September 25th. I know that we have moved into phase 3. I do not know exactly what that's going to mean for us, but we have a division meeting at 2 o'clock today. And if anything changes and we're going to be able to test on campus instead of ProctorU or whatever this means, I will let you guys know, or somebody will let you guys know. Any questions?
I just wanted to clarify, you're going to put, you want us to do chapter 35 without a recording, or are you going to put a recording up?
I think I understood what you said, but it kind of sounded weird. So chapter 35, you will not have a recording.
Okay. And if we already paid for a test on ProctorU, can we continue to take the test on ProctorU?
Could anybody else understand him?
Not at all.
I think he asked something about taking the test on ProctorU.
So as of this moment, our tests are still going to be on ProctorU unless I find out differently today.
Why can't we go up to the school if we're in phase 3 for tests instead of keep spending money? That's kind of crazy.
So that's what I'm expecting to talk about in our meeting today.
Kelly, can you mute your microphone because it's making everybody sound weird? Can you say this?
Okay, I think it's muted.
Yeah, his is muted now. So why did you say they said we couldn't?
Well, they haven't today since we went into phase 3. Phase 2, we couldn't because there could only be 10 students in a room. From what I've seen so far with phase 3, we can have the rooms at 50% capacity. So I'm gonna, waiting for the 2 o'clock meeting today to see what's decided about testing.
Okay.
So we'll let y'all know after the meeting. I know it's going to be, everybody's going to be asking that.
Yeah, that would be awesome. Because that doctor is horrible.
Yeah.
Ms. Knight, I've already paid for the 3 tests, and I go ahead and keep it on ProctorU.
So we'll find out what to do because I know many people have already paid. And if they change it, we'll have to find out either do you get your money back or do we just stick with ProctorU? I don't know. We'll find out. That was my first thought.
I do know that because Felicia and I were actually dealing with this last night, that if you have to cancel an exam through ProctorU, they instantly put the money back on whatever card you used for payment. So, because I've already paid for all 32 as well, Kelly.
Yeah, it refunded me. I hit cancel because I had scheduled the wrong one for farms. And as soon as I hit cancel, I got an email saying my card was refunded.
Okay, good. So don't do anything yet until you hear from us. Okay. I think that's it.
Thank you.
All right. We'll see y'all later.
Thank you.
Bye.
Is it over? I
It's
just got
over.
it back. I'm sorry.
It's okay. Bye.